you very much. Just as my aircon just comes on to blast, so I hope you can all hear me over the noise of the aircon. It should switch off very shortly. Thank you for letting me speak today. And I was given a very, very broad topic, that of innovation in healthcare. So that was very interesting, deciding where to actually start with that. But before I start, Barry mentioned at the beginning that this webinar was, going to go across the party benches, that it wasn't political in any way. And I want to follow in that same theme by making a disclosure here that obviously I work for a medical device company who provide, ventilators and anesthesia machines. But my invitation here was really to bring across to you my experience, from working around the world, the things that I've seen, what I consider to be best practice, and to bring those through to you today. So in that, I'm taking a very impartial view. So some of the topics that I'm going to cover, touch with what my company do as business, but there are also other areas which are outside of the scope of our business, and which make up a bigger picture. And so with that, I've tried to be neutral with some of the pictures and images that I use, but some of them are obviously from Traeger, my company, but others do actually include solutions from other providers and even some of my competitors that I've put in there as well. So some of the hospitals that I've referenced as well that I'm going to tell you about, they're usually ones that I've been directly involved with, ones that I've visited, but also ones which I've worked with indirectly, some of them as customers and some of them not. So as you probably just heard, I'm originally from Huddersfield, as I'm a Yorkshireman, but I've traveled quite extensively, lived abroad in Singapore, Germany, the Netherlands, now here in the United States. But my, origin was from Huddersfield, born in Huddersfield Royal Infirmary, worked as a staff nurse on the intensive care unit in Hull. And you can see on the map there the number of countries that I visited across the globe for work. It's currently up to 89 countries. But what I've been able to, glean from that is that the world is far from homogenous. It's very, very different. There are lots of different aspects to healthcare pertaining to culture, pertaining to the resources, pertaining to the governmental and healthcare infrastructures. But what we do share very often is some of the same goals. So this one that you see here on the right-hand side is called the quadruple aim. And it's really come from the United States, but it's actually something that I think is very applicable throughout the world, including to the United Kingdom. So what we're looking at here is obviously looking at the best outcomes for patients, driving that forwards. But we are also doing that under very, very stringent, cost requirements, especially here in the United States, where the cost of healthcare is outstripping, anything else in terms of earnings and GDP. And so everyone is trying to sort of look at how we do the best for patients and to get the best from the available resources. And of course, from that, we want to, give patients the best experience as well. But something that Alice touched on in her presentation, which resonates with me, is the well-being of the care team. So the staff satisfaction, because staff are now upwardly mobile. They can, go on and to get other jobs. You heard again what Alice said about the number of nurses and healthcare workers who are considering leaving the profession, but others, go abroad as well. There's a big proportion of British nurses who or doctors who are currently residing in Australia, and some of my friends are among them. So when we heard the first presentation from what Alice was saying, and in some discussions we had before this webinar actually started, looking across the care continuum, you've heard some of the tactics that we could have to actually try and promote a healthy living, to try and prevent disease, so the use of primary health care. But we can't get away from the fact that at some point, we're going to have patients, and we're going to have them inside hospitals. So today, my presentation is really going to focus on the services and some of the innovation that you find in those acute hospitals. Here, looking at how patients come into hospital, usually through something like the emergency department, the accident emergency, and then going across their journey within the hospital, their treatment, and then going obviously back out into the community again. And you heard again Alice's perspective on what she saw in Scandinavia with the use of the hotel as a kind of step-down facility. And so this brings us to a question about the role of the hospital within the community. And certainly, while it plays a very prominent role, the trend is probably going to be in the future to try and keep people at home through doing things like remote monitoring, and try and keep them there rather than coming into the hospital. And in places like the United States, there are certain ways that the insurance companies try and incentivize healthcare providers to try and do exactly that. But this is a quote I quite liked, because sometimes we can get very rigid ideas about the building, about hospitals. But Leland Kaiser, so from Kaiser Permanente, he said the hospital is a human intervention and as such can be reinvented at any time. So what I'm going to talk to you about is basically what I've been seeing from around the world, both in terms of the building, what the designs of hospital layouts that I've seen, the trends that are there, but also then I'm going to focus in a little bit about the technology and areas of innovation that surround that as well. So of course, when you're thinking about hospitals of the future, even today, you have all these wonderful and pretty wild, concepts. And it will be interesting to see where we go in the future. As I just mentioned, will the hospital expand with the number of elderly patients and the number of chronic diseases, which certainly the Western countries are going to have to address in the future, or will there be less beds? So exactly as Alice just mentioned again, that there's a shift to home care for those less seriously ill patients. What we do know is that the patients in hospital, and particularly in the acute areas such as intensive care units, will probably have more and more complex pathologies. And this will be aided, by precision medicine. And again, it was something that Alice mentioned in her presentation about tailoring therapies, really personalizing healthcare based on the individual characteristics, on genetic markers, on the risk profiles, and those, concepts as well. So here you can see a picture of, very nice hospital room. If they all look like that, that would be fantastic. And at the top, this is a concept bed for an intensive care bed for the future, where rather than having a monitoring device displaying on the wall, this is now projected sort of as an integrated part of the actual bed itself. So maybe we see that at some point in the future. But maybe the future isn't as far away as you would think. So this is something which a number of hospitals have used. You've seen them a little bit in Japan, but Tommy, the robot nurse here, was actually used in the pandemic in Italy. So really at the epicenter of the COVID-19 battle. And they actually had 6 robotic nurses, which are, about the size of a child. And they stay in the room and actually monitor the parameters from the various equipment and send that information to the clinicians. But rather than just, relay that information, they have a screen which can allow patients to record messages and send those to doctors. So, what is the benefit of this? You could argue that it's rather impersonal having such devices, when you could have human-to-human contact. But of course, we're in this situation where, hospital staff are at a premium, where staffing levels are challenged. So here, especially in the COVID situation where, there were a lot of patients coming into the hospital where staffing ratios were under pressure, this could free up, clinical staff to focus on those more critically ill patients. And of course, it also protects again for clinical staff as well, because, they may not have to go into the rooms quite so frequently to gown up, to put on their personal protective equipment, to go in and, to put themselves at risk of infection in that case as well. But one of the main things that I've really seen over the last 10 years or so has been this shift towards creating a healing environment within the hospital. And so if I think back, to my days in the United Kingdom, but also when I nursed in Germany, nursed in Frankfurt, and also from some of the Nordic countries, you still have a very clinical look and feel to hospitals, particularly the rooms as well. But here you can see other approaches, and these ones have really, been driven very much out of the United States here. You would expect some of this, especially for children's services. So this is the Florida Hospital for Children. You can see the different uses of color. You can see the uses of projected images onto the walls. The look and feel is very, very nice. It's very, not very clinical. The waiting areas are well designed. They're not formal or boring or cold or impersonal. And so this is a way that people have been trying to design these spaces to try and, remove the stress and tension that patients have, when they actually come into a hospital. And born from that is, the use of green spaces. Now, where possible, through atria and things like that, a lot of new hospital builds have incorporated, trees and plants and water features into those designs. But of course, that's not always possible, and it's not always possible if you're refurbishing a hospital. So here you can see some of the uses of mainly graphics that you can put up on the walls, on the ceilings that you see here, which just give a nice feeling to this. So this use of art, this use of lighting, creates a very nice environment, but also can help orientate visitors, patients, and even staff to where they are in the hospital. And that also is a very, very good thing. Also designs, things like the reduction in long corridors, with lots of staff walking up and down, specifically on a night, creates a lot of noise. So thinking about some of the workflows there. I mentioned the emergency department, or the accident emergency, as we call it in the UK. This is, the entry point for many patients within the hospital. Now, some of the designs that you see here obviously are coming from the United States, and they have a different model over there because basically hospitals are competing against each other. In the UK, we don't have that. We have one national health service, And apart from, a brief time, I remember in the mid-90s where we had the internal market, where there was a bit of competition between, hospitals. Basically, hospitals in the UK don't tend to compete against each other so much in trying to attract patients in, to attract the footfall. So there is kind of a slight different way or motive for doing this in the United States and also in other countries as well, such as Singapore. But I think we can still be inspired by some of the goals and aims of creating these spaces to, the way that we try and break down those very formal and very cold and impersonal waiting rooms, with the use of the furniture spread around, not in lines, to really try and reduce stress there. And also to look at, how we can maximize the use of space and the use of staff ratio. So one of the common ones is this ribbon design for A&E optimization. I'm sorry I don't have time today to really go into some of these in detail, but again, later on, if you want to speak to me about this, I'm going to give my contact details at the end. Alice mentioned already the healing environment. So actually looking at the bed space here, we're moving away from those sterile clinical looking rooms, the use of wood and natural lighting. But here you can see on the right-hand side from Farrer Park Hospital in Singapore, how a lot of those gas outlets for oxygen and equipment are now actually hidden behind, the bed head. Or down on the bottom of the slide here, you can see again those clinical outlets, which remind you that you're actually in hospital, can actually be, when not in use, hidden behind things like pictures. I've seen some pretty awful pictures, but I gather that you can actually choose the picture that you want to obscure the equipment with. And of course, use of light. So obviously, where you can use natural light, that is very beneficial. And there have been, again, many studies that have been done that have shown that hospital rooms which have access to light, especially in the morning, actually have a reduced number of days actually spent in the hospital for those patients. So they've been able to reduce the length of stay. But of course, that's not always possible. And so the use of this circadian lighting, especially in units like intensive care units, which are 24-hour units, to try and reduce the impact of sleep deprivation and ICU psychosis and delirium and things like that. So we can use lighting to try and orientate the patients to the correct time of day. Again, there's a load of studies and research that have been done on actually the effects of colors as well on therapeutic impacts. And being able to dim those at appropriate times, run various different light sequences, and to be able to do that while at the same time being able to provide the staff who are looking after the patients with some form of workplace lighting, which also doesn't affect the patient directly. Now, I just thought I would mention before I move on to the next topic, the considerations in designing post-pandemic, because I've seen a number of things which have come up in the press. On the right-hand side was a project that I dealt with, I think, about in 2012, which was a new build hospital in Chicago, Rush Medical Center. And you can see from the design of the building that it's, pretty, modern, futuristic looking. Actually, the design of the wards created a number of interesting challenges in terms of being able to observe the patients. But they actually had a lot of foresight when they built this hospital. and they were actually in a very, very good situation and position to respond to the pandemic, because they were able to scale the number of ICU or critical care beds and turn these into these infection control rooms using positive pressure, negative pressure, I should say, the negative pressure rooms. So they built in certain amount of scalability. So when there was overspill from the traditional critical care beds, they were able to meet that and still, protect staff and still, try and keep as much infection as low as possible, cross-infection with that. And they also built in other things like decontamination pop-ups in the ambulance bays as well. So there are a number of things which you can do to this Tang Tok Seng Hospital in Singapore. They also did exactly the same, but theirs wasn't through foresight like Rush had, because Singapore was directly impacted by the first SARS outbreak back in around about 2001, 2002. And they really learnt a lot of lessons in Singapore from that, and also built in that scalability. Also impacted at that time from the original SARS pandemic was Hong Kong. They were also at the epicenter, and so they actually built in purpose-built isolation intensive care units, which are only opened during times of flu epidemics, or now with this situation here. And they built into things basically a one-way workflow. So this is something that we're all kind of used to now. Here in the United States, when the pandemic hit here, one of the things that they introduced was one-way workflows within the supermarket. So, to minimize the risks, when you were shopping. But of course, this was born out of situations like you see here in Hong Kong, and the fact that they had this one-way workflow, how clean linen was brought in, how dirty linen was removed, and things like that. So lots of possibilities there.
Very good.
So just to quickly finish on a thing that I just wanted to talk about, which kind of links into all of this. And I see a lot of trends out there around the world. So looking at particular the big data. So a lot of hospitals are now starting to create these data lakes, where they are taking data from all the devices and all the systems and depositing it in these data lakes, which they are then, going back and taking the data from to use things like on analytics to see how much, for example, anesthetic gas consumption that they're having, the number of alarms which are going off in a particular unit, but also those for research purposes as well, to do clinical studies. And so a lot of these things are being enabled by the Internet of Things, and in particular now the Internet of Medical Things. So devices that didn't, in the past normally have any degree of connectivity to a network are now becoming networkable. And so you're starting to see this and the collection of even more data. This can then be exported as well into electronic medical records, which are, particularly important in places like the United States, where there has already been that level of digitalization. But the one I just wanted to touch on was the top topic, which was interoperability. And this has become a very important topic over the last few years. But again, the pandemic has really heightened the awareness of interoperability because of this requirement for data sharing. So we have all this data that we're getting on patients, and what do we actually do with that data? And how do we share that data between different organizations, between different departments, and how can we optimize that? Because people believe that had we been able to detect those COVID-19 cases earlier, we could have actually helped mitigate the spread, through these topics on interoperability. So interoperability is basically this connectivity between systems and devices, creating new applications to access, exchange and integrate data in a coordinated manner. And so this is really to hopefully optimize the health of individuals and populations globally. And it's a very, very wide topic, and I can't cover it all today.
Can we move on, Richard?
Yes, certainly. Okay. So we can do that. And this is what we're trying to avoid, is this haphazard amount of equipment that you see piled up everywhere. This one is an example that I saw in New Zealand. And by connecting these systems and devices together, we can create different concepts which can also help the patient outcome and the healing environment. So one thing that we've seen from the pandemic is, remote control of devices, rather than going into a patient vicinity, being able to manipulate that device externally. And this started off with the Ebola, or driven out of the Ebola epidemic that happened a few years ago, but has now really taken, even more momentum because of the situation we've had here. Now, I've mentioned the healing environment in terms of how it looks, but if you have the most beautiful hospital room in the world, but you're being kept awake at night because of all the noise, then that is not conducive to a healing environment. So using this connectivity, using this interoperability, people have been able to connect devices which are alarming and put this all together, and to automate therapy, and to connect all this together is a part of data management.